Welcome to the Livelong Podcast, where your health is your power. I'm your host, Rachel Lehman Haupt. Today, we're talking about the transition into perimenopause and menopause, which often arrives with unexpected symptoms. It can also be a very powerful opportunity to protect your long-term health. Our guest today is Dr. Ghazaleh Afshar. She's a board-certified gynecologist and lifestyle medicine doctor who has built her practice on helping women navigate midlife health through evidence-based care and lifestyle medicine.
Thank you so much. It's so wonderful to be here.
So you practiced in a traditional clinic for many, many years and then decided to start your own practice. Talk a little bit about what inspired you to go out on your own.
Well, just to take it back a little bit, just to talk about my practice, I was for 18 years with a corporate, more or less corporate company here out in California, and but felt very, very comfortable in that space where what I call traditional medicine, where you kind of have the expectations of your patient population, you have dedicated time, which is set by someone else in terms of how much time you can spend with patients, and really navigate a system that is kind of preset as opposed to something that you can develop and cultivate for yourself in a way that feels more authentic to what your desires for your practice is. So, so for 18 years, it felt very comfortable. And, truth be told, it really wasn't until I started going through my own midlife and perimenopausal changes and experiencing more personal, unfortunate experience with my mother going through a medical condition of breast cancer and having to deal with taking care of a parent that was sick.
So you needed more time and more flexibility. So starting your own practice sort of let you own your own time to take care of your mom.
Well, yes and no. I mean, throughout my mom's illness, and unfortunately, I lost her 3 years ago to breast cancer, and throughout that time, I was still at practice. It really was her transition that made me realize that the life that I'm leading is maybe not as authentic as it could be. Because for years, she would say, "Ghazaleh, you have two daughters. You are working so hard. Your time is split." Kind of at this point so evenly between work and maybe even a little bit more work than it is with family. So how are you going to balance that? And it really wasn't until her transition that I realized a balance would be for me to step outside of corporate medicine and do something that felt a lot more heart forward, a lot more kind of dedicated to what my desire is for patients, which is to spend more time and to have more space.
So how did that help you develop the philosophy of your practice? And tell us a little bit about that.
So the philosophy of my practice is really, I would say it stems from my own experience of how I started transitioning through transitioning into perimenopause, which was really insidious. It was not at all the classic kind of picture that we all hear about when it comes to hormonal changes. Of course, as a experienced now 20 plus year gynecologist in this field, I consider myself an expert when it comes to women's health. And even for myself, I felt, I would say, a little confused in terms of what was happening with my body, what the changes that I was experiencing. And my first go-to wasn't, oh, this is of course hormonal and this is of course perimenopause. It was really trying to navigate a system, even for a medical expert, in a way that felt a little blurry and confusing. So when I felt so at times confused and lost, I was thinking to myself, what is the average woman going through when they don't have the expertise or really necessarily the resources? I mean, I was in a system where my friends were all doctors. My friends were cardiologists, were urologists, are medical experts that I can just sideline on the hallway and do a little curb consult and say, "Hey, this has been going on. What do you think?" And I really came to see the massive void and gap of care that exists for women. And so that kind of was the light bulb of me getting more and more interested in this midlife space. And my surgical expertise, of course, is something that I love and I still continue to do, even with my private practice. I do in a different way.
So what if you uh in the I'm sorry, I'm getting I just your story made me so emotional that
Oh,
I know I was like, God, she lost her mom and and so I suddenly got like my words got all messed up.
well, I joke, but it's true. I really feel like my mom from up above, like really started sprinkling her little sparkle to impart really the importance of my role as a mother, my role as a community member. I mean, when you're working as really a surgeon and a physician in a corporate setting, you really are bound to a schedule that is very inflexible. And so I joke, but I sincerely feel like with her departure and her transition to her next I want to say journey. I really felt that was what gave me the courage to step outside of my safe space and to start something new.
Well, speaking of transitions, I mean, midlife is often defined as a time of decline. But in fact, it is really a time of transition. And can you explain a little bit about that from an emotional and psychological perspective, and then also from what you've learned from a biological perspective?
I mean, so much of this transition time is really our brain chemistry and our physiology kind of shifting from what its kind of steady state is to a new state. And so I definitely don't feel like I've declined in any way in my perimenopausal state. If anything, I feel like it's a blossom or a springing of a new chapter. And so, I don't like to use the word decline in any capacity because as women, we're constantly evolving and constantly learning what our new normal is. And I think so much of this is learning what is to come so then we can navigate around it in a way that feels, right for us as individuals. And not one shoe fits all, right? So everyone has different experiences. Um, in terms of what I forgot the question a little bit. Did you
Well,
say what to expect?
biologically, we know that it's a time of huge hormonal shift,
Right. And emotionally.
and
Of course. Yeah. So hormonally, estrogen plays such an incredible part in our everyday mechanisms when it comes to our brain health, our cardiovascular health, our muscles, our cartilage. Every little tissue in our body and cell in our body is affected by estrogen. So when estrogen starts to decline, there is this incredible shift that happens, and it can be insidious and it can be really abrupt. So everyone is a little different in terms of what presentations they have, and that's what can make it so confusing. Because having one person have one symptom is not necessarily what the expectation is for another patient. So, I always say looking to your left and looking to your right doesn't necessarily give you what you're experiencing as an individual. So, I would say the most typical and classic symptoms that patients may not be aware of is the degree of anxiety that may be new that patients experience. I mean, that to me was one of my own personal experiences that was just out of nowhere, never something that I'd experienced personally. And now that I'm in this space and I'm talking to patients, I would say, 80+% of my patients, and in terms of what the evidence is showing, really have some distortion or change of mood expectations of depression or anxiety, which is not the classic menopause symptom that most women are aware of. So estrogen plays a huge part in our neuroregulation of our brain health. So when estrogen declines or has massive shifts of uh, elevated levels or low levels, it causes patients to have shifts in their mood, and especially anxiety and depression showing up.
Well, you are talking to the right person because I can tell you that when I started going through my transition, and I'm sure so many women out there can relate, I also had vast mood changes. It was around the same time that my dad passed away. And
Mm,
so I just remember thinking, I know I'm in grief, but there's something more going on here. And
absolutely.
really the high anxiety that was, and I'm a person that's prone to anxiety to begin with. And it's interesting because you hear so many women that are going through this, and then they go to the doctor, they go to their regular doctor, and they're prescribed an SSRI. So
Hmm.
and it feels sort of like a one size fits all solution. And it feels like there's so much more that you could work with. And so I'm very interested in your transition to lifestyle medicine and how you approach this transition from an emotional and lifestyle medicine perspective.
So, for me, the lifestyle perspective and really focusing on, the six pillars, right? So when we talk about lifestyle medicine, it's really important to bring it back to what that means for us individuals. And so, really bringing back our life to a place where our sleep is optimized, our nutrition is such that we're really focused on whole foods and foods that have incredible micronutrients and macronutrients that are impactful. We're reducing our stress. We're moving our bodies. We're eliminating things like smoking and alcohol or excessive use of alcohol, especially,
Yeah.
and establishing a community where socially we're engaged and impactful. So when we bring our life to a place where we've optimized those things and we are in a place where we're more or less stable, right? When processes start to develop during perimenopause, it becomes a little bit easier to have this elimination when things are otherwise stable, right? So when we have the process of elimination becomes far less overwhelming when we know that our sleep is optimized. So when our sleep starts to become shifted or changed, it's not because we don't have good sleep hygiene or our stress is such that our cortisol is spiked unnecessarily. So this process of elimination becomes a little bit easier to say, okay, if I'm having a problem here, it's not because of these four factors being out of line. I already know that my nutrition and my exercise and my sleep and my activities of lifestyle are so stable that something is off with me. So then it becomes a lot easier to focus on on what symptoms are and how to alleviate those feelings.
Yeah, so okay, so let's talk a little bit more about the emotional because we've done many podcasts and we've talked with many experts about heart palpitations, uh, um, what are other symptoms of menopause, of
I
perimenopause?
mean, the
So,
list is so long, right? You can have ringing in the ears. You can have what's called the musculoskeletal syndrome of menopause, where your body aches. You almost feel, if not almost, you are feeling arthritic, where you feel like you have incredible knee pain. Plantar fasciitis becomes a very where your feet are painful to even walk on. Frozen shoulder. The genital urinary syndrome of menopause, when you're having vaginal and vulvar issues of dryness or burning or discomfort or bladder issues. I mean, the list is so long that I think the classic symptoms that we've heard of, which is the hot flashes, the insomnia, or just the irritability, those are the three kind of glaring things that women talk about. But those are not all women feel that. And I think when we're not having those classic symptoms, hormonal changes and perimenopause aren't really the kind of glaring issue going on, and it becomes more, oh, that's more emotional or that's more aging, as opposed to, no, this is really foundational in a hormonal shift that needs to be addressed.
right. And I think what's also very interesting is some of the sort of lesser known symptoms, particularly the psychological ones like anxiety. I mean, often, like I think somebody once even accused me of having a mood disorder,
Mm.
which was related
And
to,
that's right.
and I guess my question is it a disorder? Like if these are, things that are happening to you that are natural, To classify perimenopause as a disorder, is that doing a disservice to women?
Well, it's not a disorder in the sense that it's a natural process, right? So every woman is going to be perimenopausal in some degree, and every woman will go through menopause. So it is not a disorder of creation that you have inflicted on yourself by certain behaviors or certain lack of behaviors, but it's a natural process. But that natural process doesn't mean that there isn't help to help you go through a natural process when there's a pathophysiology being incited and there is a real shift that's affecting your activities of daily living. And just, I equate it to thyroid issues or diabetes issues. Certain thyroid and diabetes issues are natural and they are autoimmune and they are, you're born with a genetic predisposition for. So it doesn't mean that we wouldn't treat someone who has related symptoms to thyroid or diabetes or any other endocrine process going on, which is really what perimenopause and menopause is. It's an endocrine process. So, it's something that needs attention. It's something that needs evaluation. I mean, unfortunately, in medical school, what is taught in terms of menopause is a lecture, and perimenopause is really a footnote. So that is not enough education for the medical community to really be able to have the toolbox and the science and the evidence to treat women when they're having symptoms that need addressing.
It seems like naming it is really one of the most important steps rather than
Absolutely.
it off onto, oh, a random mood disorder or this is, a sign of something else, but actually naming it as what it is and linking the symptoms to it so people don't feel alone and you also don't feel like you're going crazy.
Right. And I think, unfortunately, in medicine, the way that, really corporate medicine or medicine is today is that everything's so siloed, right? So you go to your doctor, you have 10, 15 minutes to have a conversation about everything that's going on. And so when a mood symptom comes up, it's really easy to silo it to, psychology or a psychiatrist or someone who is not your primary care doctor. Or if there's, symptoms that are going on that are musculoskeletal, to have you go see an orthopedic surgeon or someone else. So this siloing of symptoms becomes such that patients feel really dismissed and unheard, where they go in to talk to their doctor and they're kind of left with a piece of paper of talking to someone else, and someone gives you talk to someone else. And so you really need to find someone who's able to connect all these dots and to put a label on what you're feeling, which can very well be perimenopause or it could not be, but it's really a conversation that every woman deserves. And symptoms, like I said, it can be insidious or it can be really kind of blatant in your face. But regardless, it's just having that space and the ability to talk to someone about it and for someone to put the dots together.
That's one of the best explanations I've heard of the dismissal that so many women feel that I've ever heard, really. The
Mm,
explanation of it's not necessarily, always sexism. Often it really is often sexism, but it is really a symptom of a system that is not looking at the whole woman.
right. And I think it's because the system is set up that is really for throughput, right? It's really kind of putting out, seeing the most number of patients in the smallest amount of time. And it has to do with the fact that there's a large volume of patients and not necessarily enough providers at times, but we're really seeing a lot of patients in a short period of time. So for someone to have that designated time, and so for me, I thought having an hour and a half, I mean, my patients on my first appointment really have 90 minutes for us to talk. And sometimes that's not even enough. And so that is really trying to get that whole picture of getting every lifestyle pillar and element discussed, getting all their symptoms discussed. So it really takes dedicated time to sit through what women are going through during this really difficult time frame for some.
What would you like women to stop fearing the most about this transition?
That it's the end or a decline, or that hormones are, you know, dangerous in the sense, unfortunately, the Women's Health Initiative back in 2002 really instilled an incredible fear of hormones and cancer and its related issues of cardiovascular disease or stroke. But now that we're 20 plus years after that time frame, now we have 20 plus years of evidence that really shows us the opposite. It really gives us information telling us that hormones are not to be feared in the sense that they were described in 2002 from the Women's Health Initiative. And if anything, it is a very nuanced conversation that every single individual at any age in terms of women need to have with their providers. It's not a you are not a candidate and the door is closed kind of situation.
And as we get more towards a world of precision medicine and individualized medicine, let's just hope the conversation gets even more nuanced for patients where it really focuses on their individual biology.
Absolutely. I mean, I think one of the biggest things leading up into perimenopause and menopause and knowing your own body is this idea of allowing for conversations to exist before the disease process develops, meaning prevention is really one of the key things for us. And that's really what was one of the most exciting things for me when it came to lifestyle medicine, where we're using lifestyle as a form of preventing disease processes as opposed to waiting for them to occur and then really spark into treatment and spark into action. And so for me, one of my big motivations with my patients is to really set down that foundation of health. So you're optimizing your health, not only to be able to then critically look to see, okay, when the symptoms develop, how are we going to navigate through this really stable environment and figure out how to optimize even further, but how are we going to prevent these processes from even occurring in the first place? So our metabolic health is something that I really stress with patients, and understanding if you are someone who has what's considered metabolic syndrome, and really understanding those elements, which I'm happy to talk about if that's where we want to go with this conversation.
Yeah, what do you mean by metabolic syndrome?
So metabolic syndrome are really 5 parameters that we look at. It's not an absolute risk, but it's a really significant risk of what if we do carry 3 out of 5 of the following elements, which I'll get into, really increases our cardiovascular risk and our diabetes risk exponentially. So the 5 parameters that we look at are really simple, and every patient should be able to look at their own risk at any age, but especially in midlife. So the first thing we look at is your blood pressure normal? So if your blood pressure is under 135 over 80 millimeters of mercury, then that's a normal blood pressure. But if your blood pressure is above that, or you're on blood pressure medicine, that's one of the 5 criteria that we look at. 2 is your HDL, or your high intensity density lipoprotein. And that is more or less your good cholesterol protein. And so if that number is below 50 for women, that puts you into a more concerning category. Your waist circumference for women, it being above 35 inches. Asians, we have a 31-inch cutoff. Your triglycerides is a value that we look at, and your fasting glucose. So those 5 are elements of laboratory but data that we look at, and if you have 3 of those 5 that are abnormal, you are someone who is considered to have metabolic syndrome, which can then lead to furthering disease processes like increasing abdominal obesity and visceral fat, which is something that naturally occurs as women start to enter into this perimenopause and menopausal state, then increasing our risk for further blood pressure issues and cardiovascular disease, muscle atrophy. So it's a really vicious cycle that kind of adds on to itself. So then really being able to stop it sooner than later, I think, is what is really transformative from a preventative standpoint.
Thank you so much for getting into such the specifics. I can really see that those linking those 5 issues is so important, and women can take that, like make a list, take that to your doctor, talk about it with your doctor in relationship to perimenopause and menopause. So what do you think thriving in midlife looks like?
One, feeling good. I mean, thriving looks good when you feel good. So, and then having someone that one is listening to you from a medical standpoint, but feeling good, sleeping. I think sleep is such an incredible foundation of health. So thriving is having a good night's sleep and not having disrupted sleep. So when you're awake in the morning, you can start your day and be motivated to have the energy to do all the things that you want to do. Thriving looks good. Thriving, excuse me, is something that I think all women have the ability to really love the new self that they have, in the sense that a lot of women come to me and they say, I don't feel like myself. I feel like I'm having out of body experiences. I don't feel comfortable in this body anymore. And so that to me is really difficult to hear. And when we start to make the changes that feel good, that feel right to each individual for their life, for their lifestyle, as opposed to a prescription that one shoe, fits all, is what I consider to be thriving, is to really be heard, to really feel as though someone cares to make the differences that I think all of us deserve.
Wow. Will the anxiety go away? Does it get better?
The answer is yes. But I use the 80-20 rule. I wish that the medicines or the interventions or the lifestyle shifts were a magic kind of wand, or the perfect answer to everything, and everything would be 100% better. But I use the 80% 80-20 rule, in the sense that if you're 80% better, then it's a win. So what does that look like? Really setting the appropriate expectations. I think it's important, and understanding that every decade or every chapter in life is a new chapter. So to compare it to a previous one is really a disservice to you as an individual. Not only are we evolving from a human standpoint, or a personality or a person standpoint, but we're also evolving from a physiologic standpoint. So the anxiety that is crippling, yes, that is something that is definitely something that we can help with, and help navigate through. So I would hate for anyone to live in that crippling anxiety that I think is something that no one should experience.
Wonderful. That's great to hear. And speaking of evolution, where do you think the menopause conversation should be in 10 years?
The menopause conversation should be a conversation that we have, just like we have about diabetes prevention or blood pressure prevention. Menopause should be something that is not a conversation that comes just in midlife. Menopause should be something that is taught in medical school, with the same seriousness that diabetes and hypertension is discussed. Women really are learned to kind of stay quiet and be silent sufferers. I think menopause should be something that is celebrated, in the sense that you are now understanding what your body is going through, understanding what medical interventions are available to help you mitigate symptoms, help you understand why you're feeling the way you're feeling, and help you resolve the symptoms that are crippling. And also the fear of hormones. I really hope that the fear that is incited around hormones are to a place where women are not thinking that by taking a medicine that's going to help them so much and impact their lives so much on a daily basis is in some way putting them at monumental risk. I really hope that that's not the case. And I hope that, practices like Tala's that really give that attention to women, and the time that's needed to put the dots together, become a care of access that is expected, and not some kind of outlying, bold and brave decision a surgeon and doctor like myself has to make.
Well, congratulations on making that decision and pushing us all forward. Thank you so much for taking the time today to give us your wisdom.
Thank you so much. It was wonderful talking with you, Rachel. Thank you.